Good morning and good evening, everyone. Jonathan Edelheit, CEO of the Medical Tourism Association. I'm here to present today on business opportunities in the U.S. healthcare for medical tourism and really give everyone an update as to really what's happening in the U.S. marketplace. And we're going to cover both outbound medical tourism leaving the U.S. and also domestic medical tourism, people traveling within the U.S. We won't be as much covering inbound medical tourism. That'll be another webcast, patients coming into the U.S. And have definitely a lot of slides to cover because this is a very big topic. So I'm going to run through them all. So to give you guys, everyone, an update on the Affordable Care Act, which everyone also refers to as Obamacare or healthcare reform, there's still internationally some misinformation on the law, so I'm going to recap some stuff on it. There's a lot of pages to it. I think 30 to 50 times the number of rules and regulations that have been created since the law has been passed. There's almost 180 governmental agencies, committees, and bureaus that manage the rules and regulations, so there's a lot of bureaucracy. And the Affordable Care Act doesn't really drive prices down. It actually increases prices. So I think there's a little bit of a myth that because it's called the Affordable Care Act, it lowers costs. And I'm going to go into some of those things of why it lowers costs. But, before I do that, it doesn't reduce the cost of pharmaceuticals. It doesn't reduce the cost of medical supplies. It didn't do tort reform, which is medical malpractice. So in the end, some of the core main things of why healthcare is more expensive, it didn't lower those costs. Now, if we look at where health insurance costs were before, 22 years ago, the single cost for an individual was about $1,500. And about a year ago, it was almost $6,000. So there's a significant increase, in trend of costs continuing to go up. And 10 years from now, by 2023, it's supposed to be double. So you're talking about $11,000 to $12,000 for a single person for their health insurance. If we look at the cost of family, 22 years ago, it was about $4,000, and in 2013, it was about $16,000. But family insurance is supposed to quadruple in the next decade. So that means it's going to be almost $60,000 for family coverage in 2023. So that's more than the average American makes. So it's going to be actually impossible for them to afford health insurance. So health insurance costs has continually increased. Some of the reasons why the Affordable Care Act increases costs is I'll give a little example for if you're buying a car and you buy the base model car that has cloth seats, a stick shift to drive, it doesn't have heated seats, let's say it doesn't even have a radio, it doesn't have navigation or GPS, none of the special features, and then you have a top-of-the-line model of that car that has the leather seats, it has heated seats, it's got the GPS, rear view camera, all these cool functions. You can't have better functions and better quality, but then have costs go down. It's an impossibility. So some of the things the Affordable Care Act did is its guarantee issue. It said there's no pre-existing condition exclusions anymore. Going back into the past. So that means that everyone gets coverage regardless of any health condition that they have, and they're covered right away. Where before it wasn't guarantee issue, they could deny you, and they could pre-X you. So if you have cancer, if you need a transplant, they say we're not going to cover this, or we're not going to cover it for a few years. Now they have to cover it and cover it right away. So common sense says that's going to increase costs, and you can't discriminate between the cost of a sick person and a healthy person and what you charge them for insurance premiums. So that means healthy people's insurance costs go up and sick people's insurance costs go down, and then they kind of meet in the middle and level each other off. So the healthy subsidize the sick. And then what they've seen, especially with the health insurance exchanges, is healthy people not buying the coverage because they know they don't need it and they can come get it whenever they want now, and more of sick people on it. So I want you to really let that hit home is if you're healthy, what's the incentive to buy insurance if you know you could wait until you're sick and the insurance company has to accept you? So it goes against the whole concept of trying to get people to buy insurance. And they removed lifetime and annual limits, so there might have been a $500,000 or $1 million annual or lifetime limit on an individual. Now there's no more. You could have, $5 million in bills, $10 million in bills. So obviously there's a cost to it. And also there were some other things that were done where senior citizens, older people, should be charged 5 to 6 times the rate as a young person. So once again, they said, okay, no, we're going to make it arbitrary, not based on statistics, math, or anything. Old people cannot pay more than 3 times the rate of a young person. So what does that mean? That means if old people were paying 5 to 6 times before, and now it's being brought to 3 times, then young people's rates have to go up because they're subsidizing the old people. And we've already seen over the past year what that's done is young people have said, why am I letting my rates go up and paying for the rates? It's already hard enough to get young people to buy insurance because they feel they're invincible. So the young people have said, I'm not buying insurance. I'm going to wait until I get sick and then buy it. So that means once more older people and more sick people have the insurance. Obviously, there's some real positives to the health insurance law, waiving pre-acts and making it guarantee issue. There are a lot of people who had health conditions that couldn't get coverage before, and now they can. That's great. But they missed a lot of key elements. They didn't, like I said, they didn't change the cost of pharmaceuticals, medical supplies, medical malpractice, and they didn't make individual fines as much if you didn't buy insurance. That would actually incentivize people to buy insurance. So the fines are extremely weak. It's peanuts. It's like, and they were delayed. But it's like $9 per month as a fine if you don't get your health insurance, and then they're saying, there's rumors that they're not even going to get audited or no one's going to get fined. So if you got to pay $1,000 a year for health insurance, or for your family $12,000 or $15,000, and you can't afford it, but all you got to do is pay a $9 or $30 a month fine, you're just going to pay the $9 or $30 a month fine, wait until you're sick and buy coverage. So the law was not really well thought out. There's a lot of other things, but I don't want this to be a big Affordable Care Act, Obamacare session, but just to let you know, costs are going up, they're not going down. And a lot of employers are feeling the pinch. Now, this is a critical time, I think, for medical tourism because they're going to feel that that pinch coming up this starting January. So the big part of the law was you had the employer mandate that said employers had to offer coverage, and if you don't, you're going to pay a $2,000 fine per employee. So, if you have 10,000 employees, you're talking like a $20 million fine that you'll have to pay if you don't offer health insurance for the year. So they delayed it, and what they said, first off, is that, and this was going back, this has never changed, employers with under 50 employees are exempt. There's no fine, there's no mandate. Employers that have 50 to 99 employees, they delayed the fine to January 1st of 2016. But starting in a few months, January 1st of 2015, employers with over 100 employees have to offer the coverage or get the $2,000 a month fine. So if you have 100 employees and you don't offer coverage, you're basically paying, that's $200,000. You're paying a $200,000 fine. And then if you have 1,000 employees, it's a $2 million fine. So starting this January, employers are going to get hit with some really serious fines, and they're going to look at how do I lower healthcare costs. And if you look at the U.S. marketplace, they tried high deductible plans, they tried consumer-driven plans. Those types of things don't really work. They can implement corporate wellness. It can take, a couple of years to really get a good corporate wellness program in place. It can be a little tough to measure ROI. Medical tourism, domestic international, is an instant program they can offer to lower costs. So when we look at the U.S. market, you've got self-funding and fully insured. And a lot of people don't necessarily understand the U.S. market in really how it breaks down and how it works. My background before running the Medical Tourism Association, I ran a national TPA, and we administered a lot of self-funded and fully insured plans. And back in the early 2000s, I was the first one in the U.S. to implement medical tourism into self-funded and fully insured plans back in 2003 and 4, with a lot of success. So a self-funded plan is, the U.S. is different. We don't have nationalized health care. And a self-funded plan basically is where, to really simplify it, it's an employer who says, I'm not going to work with an insurance company. I'm not going to work with Blue Cross, Blue Shield, Aetna, Cigna, United Healthcare, any of the big insurance companies. I'm going to administer my own health insurance plan and use my own money and pay for it. So they'll bring on a company called a third-party administrator. They'll do everything that insurance company does, put together a medical network, pay the medical claims, handle customer service. And the concept behind going self-funding is that they'll save money, meaning that maybe they were paying Blue Cross Blue Shield, an insurance company, $1 million per year. And if the cost of the plan was, because when you're with a fully insured plan, you have a fixed premium. So, you pay $1 million per year. It covers all your employees. You don't have to worry about the cost being higher than that. That's the risk the insurance company takes. But the insurance companies are very profitable. They're some of the biggest companies in the U.S. So you might pay $1 million for your health insurance for your employees, but maybe your costs are only $500,000, and your insurance company is keeping and pocketing that $500,000 in profit. So the concept of self-funding is letting the employer put that $500,000 back in their pocket. So I'll go into some stats and self-funding in a couple minutes, but the Affordable Care Act has actually increased and been very positive to the self-funding marketplace as more employers go self-funding, because there's some ways they can really save money. So if you're fully insured, there are certain things you have to do. You got to pay what are called premium taxes. You got to have profits, put in there because the insurance company wants to make money. You're required to have reserves for big claims. You have administrative expenses. There's certain types of benefits that you have to offer under the healthcare reform law when you're self-funded. So in the self-funding plan, you're not paying those taxes. You don't have to have reserves. You're not dealing with profits for an insurance company. So the idea is it's costing less. But it could cost more, so there's a risk to it. You could pay more, but the potential is to actually save money. Now, many people don't even realize this, but over 83% of companies in the U.S. with 200 or more employees are self-funded. So what that really means is any company that you would really target in the U.S. to implement medical tourism, they're self-funded. And because you really don't want to go into the small employers. And when you're self-funded, if you're dealing with an insurance company, because some people look at the golden goose and say, oh, if only I could work with an insurance company. They'll send so many patients. But the insurance company has a tremendous amount of bureaucracy and compliance and legal issues and politics they have to deal with, and it can take them forever to implement medical tourism. It could take them, if you're talking to an insurance company, whether it's 3 months or a year or 2 years. With a self-funded employer, you're dealing with one employer, and they can instantly make that decision. They can decide today, we want to do it. They add a small clause to their insurance contract, and it's implemented. And there are tens of thousands of self-funded employers and more coming into the marketplace every day, switching from fully insured. So versus saying, I want to go after an insurance company, you have a tremendous amount of potential clients and prospects that you can go after. So here's another great stat. 93% of employers with over 5,000 employees are self-funded in the U.S. And our estimate is by 2016, it's going to be 97.4% of employers with 5,000 or more employees will be self-funded. So what this means is this is your target, not the fully insured carriers. So one of the things is, if you're self-funding, there's stop-loss coverage. So some of the things I'm going to go into is how reinsurance works, and then who are the different types of players also in the self-funded marketplace. So, one of the biggest pieces of advice I can give to anyone on this call, if you're going after the self-funded marketplace, is understand how self-funded plans work completely, every part of it, and understand the players and understand how you communicate to them. I get questions and things that come to me all the time where people are proposing to self-funded employers or insurance agents on a consistent basis, but they don't even understand the U.S. insurance marketplace or self-funding. And they're going to get into a lot of trouble. So they don't understand HIPAA privacy. So they're presenting something that's going to violate privacy, which means the employers, once they find out, they're going to say, that's it, we're not offering it, and we're not going to work with you anymore. They don't understand ERISA, so they'll get asked questions, and they don't even know the answers in RFPs or requests for proposals. How are you handling ERISA? How are you relating HIPAA? And then I know because they really want the business, they'll go ahead and they will, they'll go ahead and ask, they might try to answer it, but they really don't answer it, and they don't also understand how to actually do it if they actually get the account. So just, and I don't, I could probably do a different webcast, maybe, maybe I'll do one after our conference, in a couple weeks. Really, going in and trying to delve into explain all this, because I think this really hurts the opportunity to get clients and to get participation, because you don't even know why you're not getting the case or the opportunity. And it would be a shame. It would suck to get a client and then lose them because you don't understand any of the terminology. So reinsurance company, self-funded employers usually get stop-loss coverage through a stop-loss insurance company or reinsurer. So what that means is they typically say, I'm willing to pay first dollar claims up to a certain amount on every employee I have. And then once I get to a certain high level dollar amount, I don't want risk anymore. So I'm going to buy this, what's called stop loss coverage. And it's a stop loss deductible. So what it means is, I'll give you an example. Let's say I'm Home Depot and I'm self-funded. I might have a $100,000 stop loss deductible on each employee. And that means that as Home Depot, I pay the first $100,000 in claims, and then once the claim gets to $100,000, my stop-loss insurer or reinsurer pays the difference. So this is why medical tourism is so attractive, is if that heart procedure that I'm sending my patient for, my employee, costs $140,000, I know I'm paying $100,000 of it. My reinsurer is paying $40,000. If I can send that person overseas and it costs $50,000, then I'm saving over $90,000, and my reinsurer is not paying anything, which means my renewals for my reinsurance and stop loss is going to be less, and they're putting that money right back into their pocket, into the company. So it has a major impact. The same thing goes, some smaller employers, they could have a $50,000 or a $25,000 stop loss. So you're talking about a knee replacement that costs $50,000. That money is, and they send someone overseas for $15,000, or not just overseas, to a different city in the U.S., all that money is going right into their pocket. And then they have an aggregate stop-loss policy. That's not as important to medical tourism, but what it says is it's a worst-case scenario for the entire company. So they bring in a reinsurance company to say, if our claims go and hit this large number overall, you'll come in and pay anything above that. So this is the example of how it could work with medical tourism, whether it's outbound, outside of the U.S. or within the U.S. Knee replacement and being $50,000. If it overseas, it was $15,000. Airfare, hotel, $2,000. You giving a cash incentive to the employee, putting a check in their hand for $3,000. You're talking about a potential total savings for the employer, $30,000. That's huge. Now, one of the things with healthcare in the U.S., just so you know, is there's no way to know what the real cost is of healthcare, and so these are estimates. I was in the insurance industry administering claims for national employers all year long. You talk to any insurance company, you don't know. You could have two hospitals across the street from each other, with one has double the price of the other. And it has to do with the hospital, the contract they've negotiated. It has to do with the physician. And then there's a lot of hidden charges that you don't see till afterwards. So you never know what the cost is. And if there's a complication, it could be more. So what the employers love in the U.S. about medical tourism is it's transparent and it's fixed pricing. There's no unknown, and they can actually budget for it. Just to, go into some of the, key buyers of who healthcare players are, self-funded employers, as I was just going on, they're the ones who make the decision. And you could decide to go directly after the self-funded employer, whether you're calling on the CFO, the CEO, or the Director of Benefits or Human Resource. They're one target that you can call on and go after. Another target that you can go after is the TPA, and you want to know who the TPA is. Because I had a call about a couple months ago of someone who was marketing for a healthcare cluster, medical tourism, trying to go after self-funded employers. And I went through, this is the self-funded employer, this is who you have to talk to with the self-funded employer. Then you have TPA. The TPA is a company that the employer outsources to, that administers all the medical claims, does customer service, and almost acts and does the things an insurance company would, so the employer doesn't need an insurance company, doesn't have to do it in-house. And then I explain also you've got brokers and agents. So they're the ones, insurance agent, they advise the employer on what insurance to put in place, what benefits, what new things to offer, and that they receive commissions for doing it. So a percentage, 3%, 5% of the cost of the health insurance. And they go out and they do enrollment meetings. So they advise the employer, this is the insurance I recommend you buy. Go self-funded, go fully insured. The employer implements it. They hire a TPA. The broker agent goes in and enrolls employees in the actual benefits. So you need the broker and agent involved in it, because if not, there's no one out there to go on site to the company to enroll and educate employees on the medical tourism benefit. And also, you need to get the broker and agent on board with it, because if they're not, they might recommend against it to the employer. They might not enroll it or educate employees, or they might say, oh, you went directly to the employer, my client, you're trying to cut me out, therefore I'm not going to recommend you. I'm not going to work with you. I'm going to go find someone else because you're a potential threat to my commission and my relationship with the employer. So going back to the, I think the story I was telling, starting a couple minutes ago, is so the healthcare marketing person for the cluster, I explained all these different roles. I spent an hour. I was really trying to help them just really understand the marketplace so they could be successful. And when I was done, she said, okay, so a TPA and a broker and agent are the same thing. And, that's where I was like, no, they're not. And I knew this is in trouble. The whole marketing plan for this healthcare cluster is going to totally not work. And so this is why it's so important to understand who are the different players and what exactly their role is and how you need to communicate with them. Because if you don't, then you're going to make a mistake, and you're going to present something to them that's totally wrong. You can't just call them up and say, hey, we have great health care, send us patients. And if you don't know what the role of each one is, you don't know how to communicate to them. And you don't even realize, I'm sure that healthcare cluster is going to get feedback that's going to say, we didn't have success. No one was interested in sending patients to us, to our healthcare cluster from self-funded employers. That's the feedback they're going to get. They're not going to get the story of, we weren't properly trained and we could not communicate professionally to self-funded employers, brokers, agents, or TPAs what our value proposition is and what we do. So that's really important. And then another part of it is education and engagement of the actual employee. This is the biggest thing missing from the industry. So, facilitators or hospitals going to a self-funded employer saying, I'll give you medical tourism, I'll do it for you for free. Not getting any money during the year for doing it, and then not having any way to educate and engage employees so they trust in the healthcare, will travel overseas, and utilize the actual medical tourism benefit. So instead it's a handing of a brochure or hoping the employer or the agent's going to do it when they're really not. So utilization and education is huge. So another player in the sector are consultants. So consultants are, think of them as the if someone on the call, I apologize, but I'm trying to simplify this for the medical tourism industry. You have agents and brokers who get commissions and offer and recommend health insurance, and then you got consultants. And so the consultants are ones who are saying, I'm kind of better than the agent because I'm not going to get a commission. You're going to pay me a fixed fee during the year for all my advice and guidance on your employee benefits or health care, and then I'm going to give you maybe not some recommendations, but options you could choose from, of which I'm not incentivized for. So almost the same as a broker or agent, very similar role, but just not getting a commission. So what's very important is if you're dealing with a consulting firm like an Aon or Mercer, and you're trying to get them to implement medical tourism, and you're like, I'll give you commission, right there, you potentially could have killed the deal if you don't understand they can't get commission, and you try to push it on them. And I've seen this. I've heard the stories of someone meeting, a hospital meeting with like a U.S. consulting firm and saying, I will give you 15% commission for every patient that you send to our hospital. The consulting firm saying, no, I don't want commission. I don't need commission. I'm not allowed. And then they're like, no, I'll give it to you. And, kind of like a little bit of an argument going back and forth. And the hospital actually thinking this is, because this is how it's done overseas, that they're just trying to be hardball. And they're saying, okay, fine, I'll give you 20% commission. And then what it actually has done to the consultant, in some cases, it's actually really offended them. And then they say, I don't want to work with these people because, it's not about the quality of care. They're almost trying to bribe me and incentivize them to send patients to their hospital, and they don't understand we don't want commission. We just want the best quality care for our patient. And one thing that you won't find in these slides is if you're approaching the U.S. marketplace, it's not all about savings. Number one is quality. That's number one. And next to that, obviously, affordability is positive. I had a call earlier with a top Indian hospital on the phone, and India loves using the term medical value travel. I understand the use of that term. I'm not necessarily a fan of that term because I don't think it has, I think it does a disservice to medical tourism. And what it's basically saying is almost, it reminds me of, going to a dollar store, you're saying it's discount medical tourism. It actually sounds like you're saying, I may not have the highest quality, but I certainly give really good value. And I think that's the wrong message, to provide. And in the U.S. market, the employers, as I said, don't necessarily care about cost. If a U.S. employer is paying $50,000 for a procedure, and that costs $10,000 in India and $15,000 in Germany, the U.S. employer doesn't care about that cost difference. They just want their employee to travel and be comfortable traveling and save that money. So if they save $35,000 versus $40,000, that's not a big deal at all. They're just excited about saving the $35,000. So don't focus as much just on price. You don't have to be the cheapest in the U.S. marketplace. But you need to focus on quality, and I think that's where if an Indian hospital uses that term, they could lose business from it, because if they're going in against someone else and they're saying, listen, we're medical value because we provide a good value for the high quality we provide, we're $5,000 cheaper than Germany, what is that going to look like to someone who it's not about the cost? It's going to look at, well, maybe you're not providing the quality, and that's why you're cheaper. And we all know, for example, India has real high quality healthcare. But focusing on that too, is this goes into the fact that, in the U.S. marketplace, you need to build a relationship with people. And this really goes for all over the world, but the U.S., very specifically, you got to build healthcare trust and relationships. Don't ever think you're going to email someone information or call them and you're going to get business and do a lot of medical tourism business. You need to meet them face to face. This is the way business is done in our industry. And if you're going to convince someone to want to send patients through you, whether it's overseas or in domestic medical tourism within the U.S., you need to connect. So in about 10 days, our 7th annual conference starts in Washington, D.C., September 20th to 24th. This is the only place in the world that brings in qualified buyers. We have over 1,000 of the buyers from the U.S. marketplace that come to the event because it's integrated with the Employer Healthcare and Benefits Conference, and you can schedule one-on-one networking meetings. So it's where you can do all your business in one place. That could otherwise take you 3 years. You can do it in 3 days. But it's important because, to give you an example, and I'm going to go into this a little later in one of the slides, is there's an employer that implemented medical tourism, a self-funded employer years ago, sent amazing amounts of patients overseas. And where did they all go? They went to India, because India was a major player in the beginning with medical tourism. Then India basically said, we kind of made it. We're getting a lot of patients. We don't need to go out and promote ourselves anymore. And because they stopped coming and meeting people, just that one U.S. self-funded employer, what happened? They stopped sending patients to India. And now they're sending them to Latin America. And people were happy going to India for care. And there's an example, too, because some people come up and say, I'm in Asia or I'm in this country with patients from America come to my country. If they'll go to India and travel that far, they'll go to other places in Asia. They'll definitely go to Europe. But we've seen the same trend where There's a hospital in Costa Rica that a couple of years ago met a facilitator at a conference. They sent them 500 patients that year, $5 million in business. And the medical director of the hospital said, we made it. We're a top hospital of medical tourism. We don't need to market anymore. They stopped every marketing. They stopped everything that the hospital did to promote themselves. And what happened? Other hospitals started meeting those facilitators and others, and they started losing business. So the thing is you have to constantly meet people, and I think more importantly is what you have to realize is whether this goes globally, so not just the U.S. market. There's new self-funded employers, there's new insurance companies, there's new buyers, referring physicians every single day coming into this space. And I think you're going to see in the next 12 months literally thousands of new buyers coming into this market. And if you're not there, you're not going to be able to meet them. So whether that's going to, for example, the Medical Tourism Association, we do workshops, we do road shows, healthcare trade missions all over the world that you can participate on if you're an MTA member. We do conferences all over the world and things like that. And then also, these slides are not necessarily in the best order, so I apologize. I'll be going back to the main presentation in a second. But we also rolled out some new benefits this year for MTA members where you can get patient leads and buyer leads during the year. And we rolled out for sponsors at our conference where they get guaranteed networking meetings. And then the networking app is one of the coolest features where you can look who's coming and schedule one-on-one meetings that happens at our conference. This allows you to also connect and network with all the U.S. buyers coming from the Employer Healthcare and Benefits Conference. Okay, so flying through these slides. So also, I encourage you to network and connect with buyers that are in some of our social communities. So, many of you might know this, but we are one of the biggest influencers in the world, if not the biggest, in insurance, human resource, meaning employers, and travel. So we actually now have about 500,000 members in LinkedIn in about 30 different groups, and we're adding a couple thousand. So I encourage you to join the groups and connect and network and develop relationships through that. So our medical tourism group has about 6,500 people from around the world. We run the biggest luxury hotel and travel group in social media with about 200,000 members. We run one of the biggest HR groups in the world with about 182,000. We've got about 10,000 people requesting to join right now, so that's going to be about 200,000 for HR. So it's a global employers all around the world. And all these groups, we added about 400,000 members this year, and we're going to be doing a lot of medical tourism education to all of them. So healthcare reform, we're talking about the U.S. marketplace. We run the biggest social community for healthcare reform in the U.S. with over 31,000 buyers of healthcare. And then we have a big benefits professionals group, which is senior executives from employers across the U.S. with almost 30,000 members. These are examples of the type of employers that you'll find at the World Medical Tourism and Global Healthcare Congress, which is integrated with the EHBC. So all the big U.S. employers, from IBM, LinkedIn, HP, LL Bean, Zappos, McDonald's, Kraft, Amex, Lowe's, NASA, Home Depot, Coca-Cola. We bring in all the big players for the conference. We bring in senior people from the administration and big employers to present. So going back to what procedures are medical tourism patients seeking who are leaving the U.S., orthopedics, hip, knees, back, spine, cancer treatments, really fascinating and cool stuff. Employers in the U.S. starting for the first time, and this is kind of, it really is mind-blowing, non-FDA approved care. So I was just, there's an employer with close to 100,000 employees right now where the CEO went through alternative cancer treatment outside the U.S. that's not FDA approved. And now they're rolling out for their employees an alternative treatment plan so they can travel overseas for cancer. Heart procedures, transplant, dental, bariatric. A lot of people don't realize that the American Medical Association deemed weight loss and bariatric a disease. So now you're starting to see this being covered and people can travel for it, and self-funded employers are reimbursing for medical tourism for it. Stem cell, cosmetic is somewhat limited, rarely covered by insurance. Infertility treatments getting covered more and more in rehab. Now, if we look at the U.S. marketplace, very fascinating, one of these surveys is if we look at multicultural Americans, So Americans who, are, different ethnicities, start with white Caucasians. 37.9% said they would go overseas for medical tourism to another country. But when you got to, that's a big percentage, but when you got down to Hispanic Americans, 51.4% said they would go overseas. When you look at Asians, 56.8%. So there's a huge market just in the ethnic and multicultural marketplace, but on top of that, people will also travel, regular Americans who are Caucasian, who are not ethnic. And why is that? Why will multicultural Americans travel overseas? No cultural barriers, no language barriers, no question about quality. Now, a couple things that come up with self-funding. The issue of a self-funded employer will say, well, I'm nervous about two things with medical tourism, quality and legal issues. Quality can be addressed through accreditation. And what almost, I would say, no one knows in the industry is the medical malpractice and liability is not an issue with self-funded employers. Self-funded employers are governed by federal law under the law that's called ERISA. And it's almost impossible to get sued as an employer for medical malpractice. There have been cases in the federal courts of blatant medical malpractice of U.S. physicians butchering patients. And the federal courts will not find self-funded employers liable for that. And then, you can ask, we've got a great advisory board of top national attorneys, and it's just a fact, but it's something that a lot of self-funded employers know and don't know, and no one in the medical tourism industry knows, so they don't know how to educate employers on this. This is a price sheet showing the cost of procedures in the U.S. versus overseas. It's actually probably, you can't even see it. This is updated. We just did this about a week or two ago. We're going to put it on our website. But it's it's a very big differential. I won't go into it. Pharmaceutical medical tourism is going to take off. You've got Sovaldi, the new Hep C cure. It's going to increase cost for Hep C by 1,800%. Instead of people needing a $300,000 to $400,000 liver transplant going forward in the future, now they can be cured with it. It's got a 98% success rate, but it's extremely expensive. $84,000 for a treatment to $140,000. So I think you're going to see, this is a price chart showing it's $900 in Brazil, $900 in Egypt. You're going to see Americans traveling abroad for it. And this is the start of a lot of large and expensive pharmaceutical drugs that patients will start traveling for prescription tourism. So I predicted it many years ago, just starting to happen. And when I say that is what's starting to happen is you're starting to see a lot of what's called specialty or biologic drugs come into the marketplace for healthcare. So drugs that cost anywhere from $20 to hundreds of thousands of dollars per year for treatment. So let's get into some of the substance. Why would an employer implement medical tourism? Obviously, we went over some of this before. Lower healthcare costs. The cost of the procedure is less. Higher quality, because if you're using top doctors and top hospitals, then the outcome is going to be better. The employees will have less complications, and they'll return to work faster. So it's a win-win for everything. Why? What's the benefit for employees? Not paying a deductible, co-insurance, co-pays, all travel costs covered for them and a loved one. So when you talk about deductibles, co-insurance, or co-pays, you're talking about potentially anywhere from, it could be $2,000 to $5,000 or more that the employee will be responsible for their procedure. So you're talking about saying, you know what, you don't have to pay that $5,000, and I'm going to hand you a $2,000 or $3,000 check to put in your pocket because of what we saved. That could be like $10,000. That is a huge impact to the average American who might be making $40,000 to $50,000 a year, and they love it. And if any of you haven't seen ABC News, the Diane Sawyer episode, news piece we put together last year with her team, or the CBS News story we did just recently, the employees love it. They love the savings. They love the experience. So HSM is an MTA member who, they saved $10 million over 5 years. It's one I was talking about before. They're a manufacturing company in North Carolina, and it's 250 employees overseas. Over 5 years, they saved $10 million. And they're going to be doing a lot more because they've changed the whole corporate culture of their company. So a knee replacement in the U.S. costs $59,000. In Costa Rica, it costs $23,000. And they had a gastric bypass, gastric sleeve, which cost $30,000. In Costa Rica, it was about $17,000. They saved about $50,000 on the procedure. They cut a check to the employees for $2,500. And we have the video on that. If you want to see it, just email us. It's a really powerful video because it follows the employees. We set it up so they follow the employees, and you hear about their experience. So let's look at domestic medical tourism. Another area that's really taking off in the U.S. is self-funded employers saying, I'm going to send my employee to one of the top hospitals in the U.S. So Walmart, all the big employers have done it. And I would say in 12 to 24 months, every U.S. employer over 5 to 20,000 lives is probably going to have it in place. So why do they do it? To improve quality of care for their employees, to ensure the right care at the right time, higher value and a lower cost. And it was transparent. Pricing is transparent. So they focused on the center of excellence model where it was voluntary procedures, nothing is forced. Everything's paid at 100%, no deductible co-insurance, and travel including is all covered. How did they choose the centers of excellence? They chose it based on it was high-cost procedures, expensive procedures, with a high variability in cost. And that was me going into before. No one knows what the cost is. So them saying, ones where we're sending employees for these procedures and the cost is all over the board. There's no rhyme or reason to what we're being charged by different hospitals for the procedure. And where travel is possible but not urgent. So, what they chose is they chose going to Cleveland Clinic, Geisinger, Mercy, Virginia Mason, Scott and White, and they chose for cardiac, and they chose for orthopedics, such as spine. So they chose those two procedures, and they projected to save employees $5,000 to $12,000 out of pocket. Another example is Blue Lake Casino. Self-funded employer, MTA member, Jack Norton's the benefits director, loves medical tourism, comes and speaks at our conference every year, and they've implemented medical tourism. They got 370 employees. They got a self-funded plan in place, and we just put together a story I think it was 2 months ago, where they met another MTA member, France Surgery, who's a Medical Tourism Association member, at our conference last year. And then Blue Lake Casino sent their first employee just recently, about 2 months ago, over Bruce Ryan, who was a 59-year-old construction manager and from California, where he went over for a torn rotator cuff for France for surgery. And he had post-op, aftercare. He got these sightseeing excursions in the French mountains, and it cost about 50% of the cost in the U.S. So it was another really great story. Jumping back to domestic, Lowe's in 2010 partnered with the Cleveland Clinic to start sending their employees with cardiac procedures to the Cleveland Clinic for care. Pepsi partnered with Johns Hopkins. Boeing's done it. All the big employers are doing it. So another key piece that I recommend that everybody really look at is, there's a company, Health Flight Solutions, that has a whole technology platform for engagement and communication in medical tourism. And the company's been around for a very, very long time. And in the U.S. market, you need a technology system. If you're going to go ahead and offer medical tourism, whether it's domestic or international, inbound, outbound, anything, you need a system in place. Everything being done in the industry right now is Outlook, using Microsoft Outlook, Microsoft Excel, and paper and pen. It's not secure. There's no continuation of care. It's very difficult to have good outcomes. To have good word-of-mouth referrals, to stay on top of things, because you're not able to track things, and there's constant violations of people's privacy. We get email all the time, private information from hospitals, from doctors, where they're just typing in the name wrong, and it's coming to us. So, it's important to implement this, and employers need it, because the employers need a system that they can track their patients going through. They can track for payments. Facilitators need it in there. And as I said, there's HIPAA privacy. And healthcare reform is underfunded, and Health and Human Resources is going to pay for Obamacare healthcare reform through fines to employers. One of those ways is HIPAA, and the average fine they're hitting large employers right now is $1 million fines for violations of HIPAA. So you want a system in place. HIPAA, it's not something you can do through paper and pen, and if you're sending emails in Outlook, you're violating HIPAA. That's a given. So what a system can do, whether you work with Health Flight Solutions or another, you get the patient portal where patients can come in and get information about the hospital or clinic or facilitator. They can look at bios of doctors, videos of patients. They can transfer their medical records in a secure fashion. It's all cloud-based. It's got firewalls, security. They can do telemedicine and talk to the actual doctor. You can have the doctor, the at-home doctor, have access to the whole thing of what's going on with the patient while they're traveling, so you have a seamless continuation of care, and the hospital can upload all the medical records going forward. So you got a totally secure platform with the employer, facilitator, hospital, everybody and doctor all in one ecosystem, and that's extremely important. And I won't go over this slide, but this is all about fines and violations. Even, the UK, for example, UK is hitting people with really large fines for breaches of data. So the system's got some other things you can do: accommodations, hotels, travel. It's got 1,500 predefined treatments and procedures in there, and you can add leads in there, and you can track the leads. So you can actually, this is a positive side for the hospital. Something we're going to really cover going forward. There is a real breakdown in the industry with hospital response to patients. And this just came up. I'm dealing with someone in the insurance industry, someone who is in the U.S. health insurance industry and wants to go overseas, and they work for a top company. And they sent an email to two hospitals. I won't name them. Two of the top hospitals, one Thailand, one India. And they had where in one of them never responded to them after the auto response. The second one had one response to them, and after they followed up, they never responded again. And how do you track that? Because if you're in upper management or you're running the international patient department or you're a facilitator, how do you know how fast people are responding? How do you know what's the checks and balances you have in place to make sure people are following up? A system like that does that, because it has auto responses, and you can send alerts and generate reports about where you are in the process, how fast people are responding, and things like that can't be done without an actual system. So you deliver a consistent patient experience through it. You can have template emails, reminders, alerts, patient process tracking, call scripts, staff instructions. I think it's a real game changer for the industry. Invoicing, payment integration, a lot of different access and different roles and settings that you can have into it. So if you're coming to our conference in DC in about 10 days, I know HealthFlight is going to have a booth. Come by, visit their booth, do a demo, or do one online. It is going to be a game changer. I think without having a system in place, it's impossible to have a successful business, because that would be like saying, I want you to write documents, but you're not allowed to use Microsoft Word. You have to use Notepad, the basic functionality that comes in through the system. Or you can't use Outlook for email anymore. Now you got to use paper and pen and use the Postal Service to send letters. It's night and day. If any of you who use CRM system, like, we use Salesforce, just for internal things and one other CRM, it'd be like saying managing without a CRM. It's impossible to do business that way. So this is a screenshot of one of the portals. This is the thing of the reporting, which I think is one of the coolest things, because I love delving into this, because we'll even use this, go in and give advice to hospitals based upon the reporting, where your patient's coming from, our marketing efforts that you're doing actually resulting in patient conversions. How long is it taking you to convert patients? So you get all this analytics that actually allows you to improve your business and be successful. So also, anyone who's on this call, let us know if you want. We'll send you a copy of the white paper we did on self-funding, so that we can actually email that to you. So anyone who's on the call, by the way, in a second I'll be taking questions. So if you want to type in questions, I'll be happy to answer them for you, on the call, or you can email me or call me. So if you're a buyer of healthcare on the call, an employer, an agent, an insurance company, you can register for free, because we have a hosted buyers program for our conference. It's at, you can go to mtccongress.com, and the code is GOMTVIP, and that'll allow you to register for free if you are a buyer. If you're not and you want to attend, just for people on the webcast, we're going to have a special extension just for today only, where you can go ahead and register and save $500 and only pay $1,500 to register. And the discount code is EBEXTEND. That's EBEXTEND, short for Early Bird Extend. And if any of you have any questions, feel free to email me at John, Jon, at medicaltourismassociation.com. You can also call me at, our office number here is 561-791-2000. And, of course, I'll be in D.C. and about leaving next Wednesday to prep for the conference. We're expecting about 2,500 attendees. And we'll be announcing some really big partnerships. I forgot to mention one key thing. We have 3 really huge partnerships that are kicking in starting this year. We just created a great partnership with Escape Artist, one of the top portals in the world for North Americans who are either retired overseas or expats or who are planning to retire overseas. Their number one concern is medical care. And we're going to be doing building out a whole medical tourism portal for Escape Artists. This should put thousands of new patients into the medical tourism industry, even as early as next year potentially. We're doing a live patient webcast at our conference with Escape Artists, where we're going to have like up to 500 or more patients, potential patients interested in medical tourism calling on. We're live from the conference floor. We're going to be talking to them, and if any of you even are interested in sponsoring and being a speaker, I'll connect you with the people on my team who are organizing that. And then in 2015, when we have our conference in Orlando, Florida, we're actually going to have a consumer day and partner with Escape Artists on that and bring medical tourism consumers to the show. So jumping into the question. And we're going to make this webcast available. Give us 24 hours. We'll send everybody on the call the video from it and everything to me. To you. So hopefully, I'll see if our video guys can even get it over to you later today, so you can watch the whole video in PowerPoint again. And then, as I said, with the white paper, we already have someone who asked for the white paper to be sent to them. And it's from the Philippines, and I'm excited that the Philippines is one of our top sponsors this year. So another question we have here is, do you think India is at a geographic disadvantage with South American countries coming as strong medical tourism countries contending, especially for the U.S. market? So obviously, I think there's a geographical disadvantage if you're further away than another destination. But what you have to focus on is that doesn't mean you won't get patients. You have to focus on quality, experience, and outcomes. And this is what all the insurance companies look for. So, for example, if you want a hip resurfacing procedure like this gentleman from the insurance industry is going to be doing and going overseas for, he's not looking in Latin America. It is close, but he knows they don't have the experience. There's surgeons in India and Asia that have done anywhere from 500 to 2,000 hip resurfacing procedures. And that means they have high volume, low complications, better outcomes. And so people will travel further distances for that. And that's where countries that are further away, that's what they should focus on, where they have higher quality or more experience in certain procedures. And then also from a multicultural aspect, if you're in India, you go focus on people who would want to come back to India. If you've got an employer, for example, with Indian Americans working for them, they're not going to want to go to Mexico for care. They'd rather go back to India. And then also the other side of the coin is, if you have an employer with Mexican employees, obviously they're going to want to go back to Mexico for care. They're not going to want to go to India for care. But there's so many prospective patients in this industry. A lot of people view it as very small pie, and they're only focusing on a small pie when it's this big, and no one's even really tapping into the pie. And then another question is, in regards to being a medical tourism facilitator, do you see a consistent way of billing patients and commercial parties? And I assume what you're saying is billing is dealing with billing for the medical claims and the whole process when people travel overseas. That's what I think that you're saying. And the answer to that is yes, you can use that technology platform to do it. If you're actually talking about getting paid and how do you get paid as a facilitator, there's a couple different models. One, getting paid a set fee from the client, the patient, or the employer, like $500, $1,000 for a procedure, getting a commission, a percentage on it, or just charging a per employee per month fee to the employer, which is typically done in the insurance industry. And then the next question is, another one says, it's still like the Wild West. Yes, it's still like the Wild West in that there's no consistent way that a lot of people present employers about how they pay. I'm a big believer in the per employee per month system. That's what employers are used to. I think it's potentially a mistake to give it away for free, as a lot have done in the past, because then you don't have any revenue coming in to support the program, educate employees, and really put in the right infrastructure within your company to service them. And then one person said, did you say a technology platform exists, and what's the name, and do you think that another platform is needed for a sort of EMR? So the current comprehensive platform is HealthFight Solutions, and obviously there are also EMR companies that do a great job with electronic medical records, and I've seen some other systems out there that you can do things in medical tourism, but they're not as comprehensive. So I think there are a lot of solutions, and everybody's got to find their own solution. And when you come to our conference, for example, that's where you can kind of demo them and see them all. Because it's not everybody might need. And everyone's needs as a hospital, a facilitator, a clinic are going to be different, and you might need something that's customized for you, or you might just need something that's very basic and simple, like an EMR. Another question from Pamela is, any suggestions on how we educate U.S. consumers for overseas healthcare? Let's see, Merida, Mexico. It said with the negative media. That I feel like we could do like maybe an hour webcast just on that, educating the consumers, or it could be a week-long webcast or dialogue and discussion. I think it's really a great topic. And what's interesting is, I know it's last minute, but this has inspired me, this question, to see if I can arrange a roundtable at our conference, a forum, with key stakeholders discussing this exact issue. Because this is where you get a lot of creative minds to come together, because how do you educate consumers? We do it through medicaltourism.com. We do it through our destination guides, our travel guides. We're doing it through partnerships like Escape Artist. We work with the media and press all the time. I think there's a lot of creative ways that you can educate U.S. consumers. One of them could be, working with us in doing medical tourism documentaries, or getting following patients to come to, let's see, Merida in Mexico. So what I'm saying by that is, we can get, if you're having patients travel, work with the MTA, we potentially can work with you to get media and press coverage. So if you get media and press coverage like we've done with CBS and ABC News and things like that, that's an amazing way where you can get free coverage to a massive audience that's really positive. And then other ways we could do it is doing documentaries, like we did a couple years ago, Angels Overseas, following an American going overseas for a double knee replacement. We're trying to find a hospital that will partner with us right now for the hip resurfacing procedure that needs to be done, following this person from the U.S. insurance industry and using our film team. And then we're going to market that documentary and give it out to the U.S. employers, give it out to patients for free. I think, in dealing with U.S. consumers, you got to be transparent. Patient video testimonials help. Doctor videos help. But I think as an industry, we can get together and look at platforms that we can develop to take this out. And I think, for example, with Merida, I think there's very specific things that we can use to try to combat that. So another question was, best sustainable practices available on conference of medical facilities, medical resorts, and medical clinics. I'm not really sure what that question is. If you, Antonius, if you could retype that. I'm not sure exactly what you're saying there. So there's a tremendous opportunity in the U.S. marketplace, whether it's domestic or international medical tourism. And I also think, for the international side, the fact that all the large employers are implementing domestic medical tourism, it's saying we totally buy into patients traveling for care. And, this year, white Caucasian babies are now in the minority in the U.S. The U.S. is no longer, it's now a multicultural country. So you have so many employers that have large populations of Hispanic Americans, Asian Americans, European Americans, and, it's no one's tapped into coming in and saying, travel back, to where you're from or where your parents are from, recover around family, and get your procedure. And I think that you would have amazing success. The first employee that ever traveled overseas under when I ran that healthcare administrator back in the early 2000s, they were working for a Miami employer of Colombian descent. They were looking, there was a procedure they needed to get, which was going to be about $32,000 in the U.S. And they wanted to go back for Colombia for it to get the procedure. We said, no problem. A week before, they said, I have no one to watch my kids. can I take my 3 kids back? Will you pay for the airfare? We said, no problem. It was like $200 each for their tickets. It cost $2,000 all in for everything for that procedure. She recovered around with family, and that's what she wanted to do, is recover with family and stayed with them. $2,000 versus $32,000. She had no question. She wanted to go. She didn't want to get the procedure in Miami. That's a massive savings. So there's a really big opportunity here. And we're also focusing on really expanding medicaltourism.com. It's our consumer site. It's the #1 site for medical tourism. And we're redesigning it, launching it at the conference. And, talk to us about how you can collaborate and work with us on that, because we want to add a lot of video testimonials of patients, of doctors, because this is the kind of stuff, we need to get stuff out there to educate people and to get them to really get involved. And then we're going to be doing a lot more road shows in the U.S., educating people and creating a lot more partnerships. Let me just see if any other questions came in. John has asked the question of, for outbound medical tourism, wouldn't the U.S. Hispanic market place be low-lying fruit for companies? Are there any companies addressing the market? So it is low-lying fruit. I think it's a huge, probably one of the biggest opportunities in medical tourism in the U.S. And are there organizations addressing that market? Not really, not seriously. Is the MTA also in that area with programs? We are. We're creating inroads, and this year we're going to have a really big push on that side with the Hispanic marketplace. And I know, John, that we still need to get on the phone and discuss those opportunities. So hopefully you're coming to the conference and we discuss them. Otherwise, please reach back out to Jessica and we'll reschedule a call to go after that marketplace. Another question, Nuno has said, I'm an orthopedic surgeon in Portugal. Considering the quality of health care here is among the highest in the European standards and the costs are lower than countries like Germany or the UK. How would you look at developing medical tourism there? I know we're in discussions with opening a chapter in Portugal, Nuno. I've been to Portugal. We had some great meetings and some workshops there about 1.5 years ago. Renee, our president's running our initiatives in Portugal, and I know she just had some more communications. So if you email me, I'll connect you with Renee, and we could really get some things. I think we're going to see momentum going back with Portugal, and I think the cross-border healthcare that's really going to kick in even more this coming January 1. It's going to create a really big opportunity for Portugal, not just with the U.S. market, but pulling from the rest of Europe also. Let's see. So someone asked to repeat the information on the discount codes. So if you're a buyer, it's GoMTVIP, short for Go Medical Tourism VIP. And I'll leave the slide up if you're just an early bird extend, EB extend, which is the $1,500 code. So Alexandra has asked the question, people from different countries have certain predetermined opinions about medical tourism destinations and quality of care. How is your position in the U.S. opinion and any countries in Europe that stand out? Great question, Alexandra. And just so you know, we're actually launching, and you're going to learn about it at the conference, and it's really exciting. It's something that has been built for a very long time, a medical tourism indexing project. And I'm not going to really talk about it because that's Renee's purview. That's what she's been building, but it's covering this exact issue. What is the perception of potential medical tourists and healthcare consumers of destinations and their quality of care? So we're rolling it out and showing, we're going to release it at the conference of the I wouldn't say ranking, but where U.S. American healthcare consumers, that order that they view from #1, I think it's down to like 20 or 25 of those destinations. And then we're going to roll that out to other countries. And that's going to be really important because people don't understand where they stand in medical tourism as a country. And then once you understand where you are, then you know, how do I change that perception? So, for example, Europe has really high quality care, very affordable prices, especially, for example, like for the U.S. American marketplace, but only recently have only specific European countries just started to promote medical tourism and actively go out to the U.S. marketplace. So I would say that predetermination might be lower for the European market, but if you start having those conversations, I think that you would find the U.S. marketplace very open because people think of Europe as modern, high quality, advanced with healthcare, but just there's not a lot of activity with them going out there. But we're going to see that in that medical tourism indexing, and we're going to see the answers to your exact question, but that'll be released at the conference. And another question was from Gaurav, and excuse me, and he said, my personal experience with doctors and hospitals has suggested that most of the patients coming to India are from Africa and the Middle East, while very few from USA. Any specific reasons for it? The reason is that Indian hospitals stopped marketing themselves several years ago. And that's why you've seen almost a stop of U.S. patients going to India. And the Indian hospitals got very aggressive in Africa and the Middle East, and that's where they're getting a lot of their patients from. And that's simply the fact. So I know the Indian hospitals are trying to get back in the game. We have a big delegation coming to our conference that's bringing hospitals from India. There are some of the government officials and industry, and then we got like the CEO of Fortis, one of the top hospitals in India, coming to speak. So I think they're really getting back on board in globally, really trying to come after the U.S. marketplace. So wow, it's 11:07. I didn't realize I ran over 7 minutes. See, I could go on for I feel like a week covering some of these topics because there's so much information to cover. Yeah, and outside of the U.S. market, we're working with a lot of the international insurance companies. We work with ministries of health all over the world that are sending billions of dollars in patients traveling overseas. It's really game-changing. A lot of people don't even realize we organize a ministerial summit at our conference, bringing all the ministers of health from all over the world. So also, any of you on the call with government, you work with the governments from Ministry of Tourism, Ministry of Economic Development, Ministry of Health, let us know, and we can, I know it's short notice, but we can invite, a government official from your country, or they could be in the D.C. at an embassy. So another question is, can you go through the most important resources required to be a part of your medical tourism business? What I would say is I don't have a lot of time to go over that because I know we've run over. I really advise you to reach out to Gil on our membership team because we built a lot of resources and tools, forms, contracts, business plans that you can get when you join the MTA. It'd be really cool, I think, for you to, if you haven't, to really call and engage Gil and find out all those tools and resources that you can get because it's really an amazing package that we kind of built over the past couple of years. So with that, I'm going to kind of close out the call. Feel free to email me, jon@medicaltourismassociation.com. And if you're coming to the conference in about 10 days, really look forward to seeing you, or if not, us seeing each other, someplace out in the world. Thanks, and have a great day. Take care.